Sir's inputs will be very important. So, good evening, everyone. We will start off today's case presentation. Dr. Nikita will be presenting. Nikita, start off.
Yes, sir. Good evening. It's a case of 56-year-old male who is a constable by profession and resident of Bangalore. Came with the complaints of painful swelling of right great toe since 1 week, discharge from the swelling of right great toe since 3 days, and fever since 1 day. Patient was apparently well 1 week back and noticed swelling of right great toe, which was insidious on onset, progressing up to above ankle currently. He also complains of purulent discharge from the lower aspect of right great toe, which is since 3 days, and one episode of fever associated with chills since 1 day. No history of trauma or loss of sensations or difficulty in movements of the leg. Patient also complains of pain at thigh and calf areas of both legs during walking for longer distance, approximately of 2 kilometers, which was relieved on taking rest, and then he could resume walking. This was insidious on onset and progressive in the last 1 year. Patient is a known case of diabetes mellitus on insulin and oral hypoglycemic agents.
One second, go back. During walking longer distance for 2 kilometers. Hello.
Yes, sir.
Yeah, sir.
Before that, how many kilometers he was walking without pain?
Sir, usually he walks to his workplace, sir, 5 kilometers away. Every day he walks 5 kilometers to and fro. Since 1 year, he's having difficulty, like he has to stop in the middle, take some rest for 15 minutes and then walk again.
Okay.
So, is there
Progressive
any,
in the last 1 year means what? The distance is decreasing, is it?
No, sir, increasing, progressive. I mean, the pain is increasing, sir. Distance,
No. What
even
about the
today
no,
he
no,
can walk.
what, what sir is asking is, you said it is progressive. Progressive means the distance should be shortening.
Yeah.
Like the disease progresses, the eventual this thing will be rest pain. So that is what sir is asking.
That is BOID 3, no?
Is that distance? Is that distance
Yes, sir.
shortening when you mean progression, or
No,
is it
sir,
only
no,
the
sir.
pain is getting worse?
Distance is not short. Severity of pain is increasing, but currently he can still walk up to 2 kilometers. Then he has difficulty, sir.
Okay, is there any
Pain is
minimum
progressive.
distance where you can cause when you can call that as claudication pain?
Sir, up to 200 meters is minimum we can tell, sir.
Shravan, sir?
No, sir. It depends from patient to patient, sir. There's not a no
I
set
don't think so. There
criteria.
is any limited distance. Correct. And can you call this as progressive if the pain worsens, or you call it as progressive only when the distance shortens?
Distance has to classically shorten, sir.
No, the distance has to shorten if it is progressive.
Yeah, patient will very clearly tell, sir. From walking so much kilometer, now I can walk only 100 meters, like that. Very clearly they'll tell.
Correct. So can this be classified as claudication pain, or is it like anything else?
I feel the patient is not telling the distance correctly. In fact, because I've seen the patient and the kind of occlusion he had. 2 kilometers is unlikely, sir. Maybe he's just overestimating the distance how much he's walking.
Distance, yeah. Okay. Nikita, you had some doubt.
Sir, previously he said that he was walking 5 kilometers, now 2 kilometers.
Okay, so it is shortened, no?
Yes, sir. In comparison to his usual, it has shortened. So can we?
I think fair enough.
Yeah, that is what is progression.
Yes, sir.
Okay.
It's a known case of diabetes.
How did that wound develop? Like, what is the cause for the way?
There is no cause as known to the patient, sir. He just noticed it at this condition, probably due to maybe diabetic neuropathy, and that's a pressure point, sir. So could be that he
So
couldn't
great toe, you said great toe, no?
lower plantar aspect of great toe, sir.
Diabetic neuropathy will not
Where
cause
is
claudication pain.
where is great toe? Sir, great toe is not. I don't think is a pressure point.
Sir,
The to plantar aspect you said great toe.
exactly where
Until
he
and unless there is a deformity of the toe.
Sir, I'll show the picture, sir, once.
Great toe is
Yeah, you share that. Sir, Shravan sir, do you agree that great toe is not a pressure point until and unless there is a deformity?
Yes, sir. The first metatarsal joint is actually the pressure point. Great
Correct.
toe pulp is
Correct.
not the pressure point. So unless there is change in the foot balance because of the diabetes, that's when the first toe pulp becomes a pressure point. That's what has happened to him. The
Hmm.
forward transference of the weight.
Yeah. So should they comment on the change of the foot shape or something in the history, or I think it is only in the examination, no?
Examination better, I feel, sir.
Better. Yeah. Yeah. Okay.
Yes, sir.
Okay. Go on, Nikita.
Yes, sir. His known case of hypertension on medication, both
no
since 30 years.
any history of rest pain.
No history of rest pain, sir.
Did
But
you mention about the ulcer, Nikita, or you just said swelling only?
sir, ulcer I did not put in the history, sir. He
Because there
just
is a ulcer,
according to
no? Ulcer and discharge is also there. So that is an important history.
sir, when asked
When you say purulent discharge, you have to say from where. If there is wound, then only there will be discharge.
yes, sir. But in the history,
And there is a wound also.
as per the patient, he told only about the purulent discharge. But on examination, we found that there is an ulcer.
There is an obvious ulcer. You should ask
Yes, sir.
leading questions on that ulcer.
No, you should ask
He
a
did.
leading question. When you say pus, when he says pus from where? It has to be from some wound, no?
No, you are
There has
already
to be a
seeing a
wound
wound.
there.
Yes, sir.
So you
But
have to
he didn't
mention
notice
about the
the
wound,
wound
how
also
it was.
Yes, sir.
How can it be? How long does he have this discharge?
Sir, since 3 days he has discharged. Since 3 days only, he just noticed
Okay.
that.
Hmm. So you wouldn't have noticed that big wound.
Actually, he didn't, sir.
Do you believe that history? When there is such a big wound.
Sir, to 3 different people, he told the same thing, sir. So, I put in his words that.
That is what you should ask the leading
No,
questions
that
about
is
the
what.
wound.
See,
No?
sometimes you have to be smart enough because you will get caught here. Examiners will think we are okay with it, but examiners will think when there is such a big wound, if you miss the talking about the wound in your history, then they will unnecessarily catch you. Shravan sir, what is your opinion, sir?
No, true, sir. We have to ask them definitely. Most of them would have left it for quite some time. So we have
Hmm.
to
Because
pull the words out of their mouth.
that looks like a callosity with ulceration long
Yes,
term probably, and then that has worsened.
yes, yes, sir.
Yes, sir. If I had to mention about the ulcer, like
You have to
patient
ask the
noticed
leading
a wound.
question. Patient sometimes might not tell the truth. If there are relatives also, you can ask them leading questions if patient is not able to communicate properly, and that looks like doesn't look like an acute ulcer also. It's a like kind of a trophic ulcer there.
Yes, sir.
So that wound would have been there for a long time, and it would have gotten secondarily infected recently. That is when he has started developing fever with chills and all that, swelling. It cannot be an acute bleb where they walk barefoot and develop acute blood and bleb, and then that leads to sepsis. The picture, if you're not put up the picture, okay, I would have accepted this. But with that kind of a picture, you can't miss the ulcer. It definitely looks like a chronic ulcer.
No, she should put the photo because the examiner will see the patient. No?
Yeah, yeah.
Yes, sir.
Correct. That's what I said. Hmm.
Sir, but
Okay.
if I had to describe it, it would be like
No.
patient noticed a wound in the great
Wound in the
toe.
great toe, which was probably there for some time, and since probably last 1 week, the patient had started to have swelling of that great toe, along with which has progressively increased to up to the ankle, and also complaints of purulent discharge and fever since 3 days from the
Okay, sir.
wound.
Okay, sir.
Okay, what are the
Yeah.
questions you will ask for that ulcer?
Sir, when did he first notice it and how did it start?
Correct.
Whether it is increasing or decreasing in the size?
And whether he has undergone any interventions for that.
Yes, sir.
What about the pain?
Mm. Pain, you spoke only about the pain in the leg. You never mentioned about pain in the foot or in the ulcer area. That is also important. No, if you have cellulitis, if there is sensation, you will develop pain in the foot or leg.
Yes, sir.
Yeah, so that is also important.
Yes, sir.
Okay.
Dr. Nikita,
Sir,
the reason these questions are asked is because they will have diabetic neuropathy, right?
yes, sir.
So, a lot of these patients may have a painless ulcer to begin with. Then, as the infection sets in and infection increases, the pain increases, or still sometimes the pain will comparatively be less compared to the clinical picture of the ulcer. Okay, that is
Yes,
one
sir.
thing.
So,
Second thing,
it can be a case of an infected diabetic ulcer, which probably with an underlying PVD, which is there already, and that worsens the gangrene, probably progressively.
yes.
Yes, sir.
And second thing, one they can also have because of the severe neuropathy, they'll be having this pins and needle sensation, burning sensation, and all. So that also you should ask.
Okay, sir.
Yeah,
Okay.
that is also very important. See, the whatever pain you are mentioning, if the claudication pain you mentioned, that is one part. Second part is invariably these people will have neuropathic pain, rest pain. Did you ask them about rest pain, all those pins and needle sensation?
I asked about rest pain, sir.
Hmm.
Pins and
Pain
needles,
and rest pain in the sense pain in the night and all that. Suddenly they get this pins and needle sensation, dragging pain, and then they will
he
not be
has
able to
this,
sleep.
sir. He has disturbed
Any
sleep,
sleep
but there is no
disturbance?
pain per se, sir.
No,
Which
no,
part of the
disturbed
leg
sleep
you
due
get
to
rest
what?
pain?
Sir,
Which part of the leg you get rest pain? How it is aggravated? How it is relieved?
sir. Usually calf region they get the rest pain.
ಏನಮ್ಮ?
Think again, ma. Think again. I think why sir is asking that question.
Is it always calf region?
Sir, it can happen due to like depending upon the anatomical segment involved, he can have pain in the different regions, sir.
Correct.
No, sir
Correct.
is
So you
asking
should
about
answer
rest
like that,
pain.
no?
Srikanth sir is asking about rest pain, sir.
Ah, rest pain. Okay. Okay.
Where does the rest pain come, Dr. Nikita?
So like it can happen either in the thigh or calf, sir, or lower back region also
No,
could be involved.
that is all claudication pain. Rest pain is only in the part of the foot most away from the heart. So which would be?
Lower leg or foot, I think. Always.
So part 4 foot, or if the pain. Srikanth sir, that's what you wanted to say?
Yeah, rest pain is always on the far away from the heart.
Yes.
Okay, sir.
What
The
are the
claudication
characteristics of rest
pain
pain?
I was talking about, it depends on where the site of this thing is involved. Sir was asking some question. Yes, sir?
I forgot. Oh, describe the characteristics of the rest pain, how aggravated, how it is relieved. All these are in DAS only.
Yes, sir.
No, it is typically in the lower part where there will be burning, aching, tingling, or numbness. And it is more at the night when patient is laying on the bed or something. And how will it be relieved? You hang the leg out of the bed.
Below
Shravan
the
sir, am I
level of the
right?
Yes, sir. Yes, sir.
Yeah. So you out of the bed, you hang the leg. So that is how the classical description of rest pain is.
Why does it increase in the night, ma? Any anybody can answer. Why does rest pain increase in the night?
Sir,
Vinod,
decreased cardiac activity during the night, sir, and it will result in further
Correct.
decreased perfusion.
Correct. And why does hanging the leg?
So, is
Effect
it
of gravity,
sir,
ma.
because of
So the moment you
gravity?
put the leg down, there is
Yes.
some mild extra perfusion. Yeah. Okay.
What is the age of the patient?
56, sir.
Shall we carry on to the next part, sir?
yes, sir.
Patient has history of CVA 12 years back, was conservatively managed. He has a history of left fourth toe amputation 1 year back and history of hemorrhoidectomy 1 year back. Personal history is a known smoker for 30 years, 3 cigarettes per day, that is approximately 100 pack per year, and previously used to consume alcohol occasionally for the last 30 years and stopped recently. Patient has disturbed sleep, bladder and bowel movements are regular and is on mixed diet.
Disturbed sleep due to what?
Sir, currently because of the pain, sir.
You said it is not due
infection
to pain
etiology.
initially.
So not the resting pain, but the infected etiology and the pain.
No, how did you differentiate that
So
it was due to infected etiology and pain?
before 1 week, he didn't have any resting pain, sir.
No, because you said you didn't mention anything about this. You just said patient this thing is progressively increasing. That's all you mentioned about pain. See, that's how you will contradict yourself and get caught in the exams. If you're mentioning about this that disturbed sleep is due to pain, you should have mentioned that in the beginning only when you're describing about the claudication pain.
Okay, sir.
Because there you
History of
said it is
presenting.
progressive, distance is shortening. That's what you said, and there is no rest pain. Now you're saying that patient has developed pain in the last 1 week.
Yes,
So
sir.
how did you differentiate between the rest pain and this the pain due to the wound or whatever in the last 1 week infection?
Infective pain with abscess. What is the character of the pain?
Throbbing
How
pain,
did
sir.
you differentiate it? Why did you say it is not rest pain?
Because from the onset of the infection, he's having the pain, sir. From the
No
history,
pain. What characteristic of that pain and rest pain? How did you differentiate? Okay, short duration, fine, but still the rest pain could have started 1 week back also. How did you differentiate? Why are you saying it is not rest pain?
it was a kind of intermittent
Because
and
you
throbbing
said
pain, sir.
because you said sleep is disturbed due to pain. So that means to say the pain is there or not there in the rest of the day.
It is there, sir, from 1 week.
No, that is what I'm asking. Is it a continuous pain and is it getting worse at night? Or it is only there at night where it is severe, where it is disturbing the sleep, or it is coming and going? So that is what I want to know. How did you characterize it as pain due to infection?
It was intermittent throughout the day, sir.
Madam,
How can it be
madam,
intermittent throughout the
infection
day?
will be intermittent. That means intermittent infection, is it?
Sir,
You are
Is the
yourself is
infective pain
like you're
intermittent?
contradicting yourself. You're saying interrupted and throughout the day. It either has to be throughout the day with on and off exacerbation, or
the
it has to be intermittent pain,
sir, it's throughout the day with on and off
or it is
acceleration,
only
sir.
at night. So it is more at night.
Not significantly more at night, sir, but it's in comparison to the
No,
day.
because see why we are talking all this is because you said disturbed sleep. And disturbed sleep, when we asked why, you are saying it is due to pain.
Yes, sir.
Shravan sir, your comments?
Sir, once infection is set in, unlikely it is intermittent, sir.
Yeah, so it has to be continuous. And can we call that due to underlying claudication, it is more at night? The pain, maybe rest pain, patient is getting into rest pain,
Maybe
Claudication
mild, sir,
pain
but
will
or
not
it is
get
only.
worse at night.
difficult to tell, sir. Difficult to tell, actually.
Yeah.
Simple to put it very simply in exam, just we can just tell continuous and leave it off, sir.
Yeah. Don't contradict yourself and get into trouble.
Okay, sir.
So you say the patient pain is there throughout the day, probably so because of the worsened because of the recent infection.
Yes, sir.
Yeah. Go on.
Summary of the history. A 56-year-old diabetic and hypertensive male with previous left fourth amputation and grade 3 intermittent claudication pain since 1 year, presented with 1 week history of swelling of right foot and fever associated with discharge from the right great toe. In this, I would also like to add the ulcer part, sir, like
Ulcer, yeah.
with associated with wound with the discharge from the right great toe.
Now, why do you say it is grade 3? So,
Because he's stopping.
anybody else? Samir, what is grade 3? Grading of claudication? Samir is there, huh?
Yes, sir.
Samir is there, no? Logged in? No.
Yes, sir. I think he's
He's
in
logged in, sir.
traveling.
Is traveling. Okay,
Yes, sir.
Anas? Anas is there or not there?
She's not there, sir. I don't know.
She's on duty, sir, I think.
She's
Maybe.
on call.
Okay. Praveen? Grades of
Sir,
claudication.
sir,
She has said grade 3,
based on-
no?
yes,
What
sir.
is that?
Sir, actually, it won't be grade 3, sir. Grade 2 according to Rutherford's classifications.
Ah,
Grade 0
Grade
asymptomatic,
2.
grade 1 mild, grade 2 moderate claudication, grade 3 severe claudication.
No,
Fourth
which
is
one you're
rest pain,
talking
sir.
about?
This is Boyd's
Which one is talking about?
claudication.
Sir,
No, Nikita. I'm asking Nikita, what were you talking about? Which one?
Sir, I was telling from the Boyd's classification, sir.
Okay.
1, 2, 3, 4 classification.
Ah,
That's why in exam you should mention class week. This is the class as per
because
this, like that.
yeah. So you have to mention there are different classification, no? Boyd's, and then there is Rutherford, and
Yes,
then
sir.
there is, I think, Fontaine.
Then
So you have to tell in each there is different this thing. In grade 3, in Fontaine classification, it is ischemic rest pain.
Yes, sir.
And Rutherford, it is grade 3, it is minor tissue loss. So that is what you have to mention. Okay, fine. Sir, any questions till now, sir? Anything you want to add or ask? Nikita, what is your this thing diagnosis now based on history?
Sir, based on history, the peripheral vascular disease with
No, your
with secondary
examination is over. I want history, yeah.
History
only history.
summary.
Okay. Sorry, sorry.
Peripheral vascular disease with secondary infection, sir.
How you forgot diabetes?
Sir,
Diabetes is also an important factor,
Why
no?
should peripheral vascular disease produce infection?
Diabetic foot infection with underlying peripheral arterial disease.
okay, sir. Okay, sir.
Shravan sir, how will you put it, sir?
You can say diabetic foot with abscess and
Underlying.
Sir. Definitely both has to be
Sir?
mentioned.
Yeah, okay. Because you can't
Both has
miss
to be
miss
mentioned.
diabetes.
Definitely, sir.
You can't miss diabetes, Nikita, because if you miss diabetes, that like it's like almost neglecting the most important part there. The
Yes, sir.
infection in the primary site will start off with diabetes due to underlying uncontrolled diabetes only.
Yes, sir.
Yeah.
So diabetic foot
Foot
with
infection
cellulitis.
with abscess with underlying peripheral arterial disease
Oh, okay, sir.
and intermittent claudication.
Yes, sir.
Yeah.
Sir, should I mention both, sir, like peripheral vascular disease and intermittent claudication? Because arterial disease itself will comment that.
Intermittent claudication is a symptom or sign, symptom.
Okay, sir.
If diagnosis, you tell peripheral vascular disease.
Okay, sir.
Sir, should they mention grade here along with peripheral arterial disease, Shawn sir?
You should
They
mention
can,
void ಸಂತಲ್ಲಿ bracket ಅಲ್ಲಿ.
they can mention, sir.
Yeah.
Okay, sir.
Okay. Move on.
General examination, patient is conscious, coherent, and cooperative. Is well built and moderately obese. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or chylomicria. Vitals, temperature 99.1 degrees Fahrenheit. Pulse rate was 88 per minute, measured in the right right radial artery, and volume normal, rate rhythm regular. Blood pressure 140 by 90 mmHg, measured in the right brachial artery. SpO2 98% on room air. Respiratory rate 18 per minute. After informed verbal consent, patient is examined in well-lit room with attender with adequate exposure of patient from groin to toe. On inspection, mild diffuse swelling of the right foot.
Hold on, Nikita.
Sir.
Shawn sir, should they mention about the gait here?
Sir, most PVD patients will be unable to walk. So it is fair enough to say
Okay.
patient unable to walk and hence gait not assessed.
Yeah. So they should proactively mention about the gait, no?
Yes, sir. Yes.
Yeah.
Okay. Mild diffuse
Okay.
swelling
Move
of
on.
right foot up to above ankle seen, associated with mild blackish or dark color discoloration of right great toe. And there is
Why
a
do you use the word mild? Is there any classification, mild, moderate, severe?
nothing in specific, sir.
Just
Relatively
tell
to
blackish.
blackish. Okay,
There
sir.
is blackish discoloration
Okay, sir.
or there is discoloration.
So, there's a hypopigmented patch, probably healed ulcer, noted on the mediodorsal aspect of the right great toe. The soaked dressing seen over the right great toe, and on examination, 1 into 1 centimeter punched out round ulcer with
No,
well-defined
you should not mention about soap dressing and all that because you will be examining the patient of taking out the dressing. So that need not be mentioned. Is it necessary, sir? Shawn sir?
Only the ulcer you should
No need.
describe.
No need.
directly.
Just mention about the ulcer, yeah.
Okay, sir. Margins with active pus discharge noted at the plantar aspect of the right great toe. Left foot, fourth toe amputated status, healed well, no other findings
Madam,
noted in the left foot.
what are the features of the ulcer? Inspection, palpation.
Yes, sir.
Sir,
On
she's only
inspection,
talking about inspection now.
Yeah, tell the inspection findings.
sir, well-defined margins and rolled out, punched out edges.
Is there anything called well-defined margins in ulcer?
Yes.
What are the types of margins in ulcer? You call margin or edge?
Um,
You can
both,
call
sir.
that as a margin also.
Margin,
Yeah.
use it in the well-defined margin, use in the swelling.
See, margin is the transitional zone between the demarcation zone between the normal epithelium and the ulcer.
You should comment on edges. What are the types of edges of the ulcer?
Edges, union between the floor and the margin of the ulcer.
Yeah, tell me what is the edge is that?
Sir, punched out edges, sir.
Yeah, you tell that. Then what else you should see in inspection?
The floor of the ulcer.
What do you see in floor of the ulcer?
Sir, whether granulation tissue is present or slough.
Whether it is healthy granulation tissue, pale granulation tissue,
Pale.
whether
Here
the
in this,
discharge is pus or watery.
yes, sir. Here it is a pale granulation tissue with pus discharge, sir.
Surrounding areas of inflammation.
You tell, no talk. You're saying surrounding there is yellowish discoloration. Is this, I think there is an abscess there. Correct.
Yes, sir.
So you got to speak about all that.
You have not mentioned about the callus at all, no? There's a very frank callosity in the first toe, no?
In the surrounding edges there, no margins of that ulcer.
A very
It's
clear callus is there.
elevated. At the margin, that is elevated. That's a callosity.
Okay.
So you can straight away mention there is a callosity with ulceration, which has a punched out edge, and then there is probably slough, and there is surrounding probably abscess due to we can see the yellowish discoloration, probably suggestive of an abscess, underlying abscess.
Yes, sir. Induration versus callosity, I can directly comment it on the as the callosity only, sir.
This is
Induration
see
is a
clearly, no?
induration is a palpatory finding.
Palpatory finding, yeah.
Okay, sir.
You can see that thickened skin, which is like different from the other part of the skin. You can see that thickened edges, no, there.
Yes, sir. Yes, sir.
Thickened margin there, full at the margin of the ulcer. That skin is thickened, which you can clearly see in the photo. You can't miss that callosity.
What does the thickening of the skin at the margin indicate?
Inflammation, sir.
No, it's a chronic ulcer.
Yes, sir.
Yeah, move on.
On palpation, there was local rise of temperature felt over the right foot up to the ankle. Tenderness elicited over the right foot. Inspectory findings were confirmed in the
No.
dorsal.
Why are you drilling right foot? You should palpate around the great toe, not the foot.
Sir, there was
Look,
cellulitis
sir,
features are
what
also
sir is
there.
mentioning is where all you have to mention. Just should not mention right foot. Was there tenderness in the toe in the ulcer area,
Where
or
do you get
was it in
tenderness
some
in the
particular
foot?
place?
Okay, sir. Different points of tenderness to be elicited.
No,
That
was
is, you are
it diffuse
examining the
tenderness in the?
local examination, madam. Great toe ulcer is there. Whether the ulcer is tender or not, it is important to differentiate what type of ulcer it is.
Sir, I didn't get it, sir.
Tender ulcer and non-tender ulcer, the diagnosis is different, no?
There is talking about local findings of tenderness at the ulcer site, or
At
is
the
it
ulcer site
diffuse
first.
tenderness in the entire foot and leg where the cellulitis is there,
That we should come
or
later.
is there both? Or is
In
there
this
both?
case, it's tenderness, diffuse tenderness over the right foot, sir.
So there is no tenderness over the ulcer.
No, sir. No specific tenderness over the ulcer.
Yeah. Okay. So that you want the clarification.
Yes, sir.
You should be cautious because the diagnosis will change.
Yes, sir. And dorsalis pedis pulse could not be felt over the right side due to the swelling.
What are the additional findings? What about this thing, base of the ulcer?
Slough present, sir. Does not bleed on touch.
Is it slough is a palpatory finding? What is the definition of base? Which year? First year or second year?
Second year, sir. Beneath the floor.
The structure on which the ulcer rests.
Yes, sir.
Well, how do you what structure it is formed? What are the this thing you should describe in this thing base? This is all MBBS question. We should not discuss here.
Where
If you
here,
palpate
what is the
ulcer,
base? What is it resting on here, Nikita?
Sir,
Here, what is the base? Here, what is it resting on that ulcer? Straight below the ulcer, what will be there here?
bone, sir.
Obvious. That is what sir is asking.
superficial to the bone, whether it is indurated or not. That's also you should mention.
If it is a chronic ulcer, there is a good chance that there can be an osteomyelitis, underlying osteomyelitis, that could have triggered the infection.
Yeah, you can get crepitus there.
Okay, sir.
Okay, move on. Shravan sir, anything else?
No, sir, we've covered.
Why do you say dorsalis pedis cannot be felt due to swelling? Can you feel the dorsalis pedis
Is there so much of a gross swelling where you can say that the pulsations cannot be felt due to swelling, Anta? Shravan
So
sir, have you seen this
this
patient?
patient had, yeah, I have seen, sir. This patient had significant
Okay.
swelling. It is fair enough to delete, sir.
Left dorsalis pedis pulse felt, which was feeble, and sensations were present on the both limbs, sir. Touch sensations. Auscultation, no
you
bruise
just
felt.
felt only the dorsalis pedis. What about the other pulses? When the dorsalis pedis is not felt, what you should do next?
So the lateral malus.
Huh?
Remaining pulse.
No, sir is asking what and all pulses you will palpate. That's what sir is asking.
You should go retrogradal one.
Posterior tibial, yes, sir. Posterior tibial, popliteal are pulses to be felt, sir.
If you are not mentioned, means you are not examined.
You are coming to that separately or?
No, sir.
No, you have to mention about that particular leg before
Peripheral
going into the
vascular
opposite side.
disease, pulses examination is the most important part.
You have to put a chart, man. You have to put a table, write down as right and left.
Right,
and then
left,
like
plus all those things.
Like lower limb you should write from DPA, PTA, popliteal, femoral, and upper limb you should write radial, ulnar, brachial, axillary, subclavian you should mention. And accordingly you should put all the feeble means single plus, normal means double plus, prominent means 3 plus. You're supposed to write like that. You
Okay,
should put
sir.
a table. If you don't put a table, that is the main thing in PAD cases.
Got it, sir.
Yeah.
Even
Sir,
the left foot is also warm.
Sir?
Sir?
No,
Yes,
tenderness elucidated on the right foot. What about the left foot? What is this thing? Temperature there? Is it cold, warm, normal?
Normal, sir.
And Nikitha, you have just said sensations present both limbs. What is the sensation? How did you check that? Is it the same? Is it altered? And what type of sensation did you check? And will it be the same when there is so much of inflammation? You said tenderness is there.
Sir,
Sir,
I just checked for the
can
touch
it be commented
sensations.
like this? Shravan sir?
We can comment. The only thing, like you said, next they'll go into whether it was fine touch or crude touch. All those things will go inside, sir.
Correct. So
Should
how
I
did you
skip
do
this
that?
or
That is
should I
what the next
describe it?
question. No, you have to, if you, in these cases, you have to describe because can be underlying diabetic neuropathy and there is already a sign of diabetic neuropathy because it's a chronic ulcer, callosity with ulceration. So invariably there will be sensation loss. So if you say sensation present both limbs, then you will get caught.
Which is the first
Was
sense
it
to be
fine touch?
lost?
How did you check? Yes, sir is asking something.
Sir, usually you're supposed to
Which
say
is the
cotton
first
wisp.
sensation? Huh?
Sir?
Allow me to complete the question. Can I ask?
Yes.
Which is the first sensation to be
Yes, sir.
lost
Yes,
in
sir.
neuropathy?
So, vibration is first lost, sir?
Did you check for vibration?
No, sir.
Then what do you use for checking? Where do you keep the instrument?
Tuning fork on the bony prominences, sir.
Then then you are told sensation or normal.
Sir, what do you
Write down
expect,
all the
Sean, sir,
points
here?
you have left. Next time you should not make that mistake, sir.
Yes, sir.
Regarding sensation, what do you expect, sir? Sean, sir?
Sir, we can't do that screening test of fine crude vibration and all. So
Yeah.
if
Hmm.
it's okay to
Only
leave
touch
it
sensation
also.
is sufficient, I think.
Yes, sir. We can if we can just tell us touch sensation. If they ask you a little more about that, we can tell us touch sensation is equivalent to crude touch. Like that, we can tell anyone, sir. And later,
Yeah.
I will use a biastesiometer to check all the sensations properly. We can just mention like that and leave it off, sir.
Hmm. Okay. And also, Nikita, you have to mention about the rest of the pulses in the left foot also. You said it is feeble, dorsalis
That is what he
pedis,
said.
ATA,
Sir said
PTA.
about the
Yeah,
Full table. Yes, sir.
figure.
Bilateral limbs,
whole table,
upper and lower
bilateral.
limbs stable.
Yeah, yeah.
Yes, sir.
Yes, yes, yes. And sir, is it necessary to mention about ankle brachial index here
Sir,
in a
if we
infective foot,
actually we have to, sir. We have to, sir.
even in
Ankle
the
brachial
infected foot?
index, yes, sir. Yes, sir. Even in infected foot.
Okay, okay.
Sir,
Nikita.
it depends. Some centers they give a handle Doppler because for an ankle brachial index you need a handle Doppler to
Okay,
correctly do it. So if they don't do it, then we can
okay,
mention that ABA not calculated because handle Doppler not available.
okay. So but they won't expect them to measure the BP and calculate. No, they can't.
We have to do, sir. Ideally, we have to do, sir. When I went for exam
Yeah,
and all, we have done by ourselves only, sir.
yeah.
We were given a handle Doppler and we were asked to calculate.
Okay.
No, sir. If there is
No,
no
no. I'm
handheld
asking
Doppler,
if there is
should
no
we also do with
Doppler,
this
can
normal
they measure
sphygmomanometer?
with the sphygmomanometer? That is what I'm
Yes, sir.
asking.
Yes, yes, sir.
They'll expect. Yeah.
They will expect, sir. Yes, sir.
Okay.
Okay, sir.
What was it, Nikita? Have you done it or no?
Not done, sir.
Okay. So how do you do it? Otherwise, in other words,
Sir, can we do it,
Yeah.
sir, with
there is no
sphygmomanometer,
Doppler.
this ankle index?
Now, do we have a
And
handle Doppler?
no, sir, it is not there.
It is there.
Not available, sir.
It is there.
It is there. It is there in
Go
the
to the
treatment
treatment
room.
room. It is there.
It is there.
Okay.
Both Vivekanand sir and Shravan sir, they check that many times there.
No, sir, if it is not present, can we do with the sphygmomanometer?
Without sphygmomanometer, you cannot do ABI. Sphygmomanometer is a minimum requirement. The question is, without a handle Doppler, can you do it or
Yes, sir,
not? The
handle
answer is
Doppler,
you
without
cannot do
handle
it.
Doppler. Yeah.
Without handle Doppler, you can mention in the exam, handle Doppler not available, hence ABI not measured. Very
Yes,
simple.
sir. Yes.
But you should, the intention is what you have to show to the examiner. That you wanted to do it, but you didn't have the necessary material, so you didn't do it.
Okay.
Yeah.
No, that what he's asking is without the this thing, just with the sphygmomanometer, can they mention?
Like
They cannot
palpatory.
No,
mention.
no, sir. No, sir. No, sir. No, sir. Just with the BP apparatus, we cannot do.
They cannot. Yeah, that is what you have to mention. Yeah.
Yes, sir. Yes, sir.
Yes,
But
sir.
you have to you have to show that intention that you
Yeah.
wanted to do that. Because of this, you have not done it.
Yes.
Yes, sir.
You also can proactively ask for it just to show that
Yes,
you
sir.
know. Sometimes
Okay,
they
sir.
may say it was here, you are not asked.
Correct.
Okay, sir.
Move on, move on.
Sir, should we mention the auscultation, sir? No blue is felt.
100% you should mention. You should mention.
You should examine the abdomen also, palpation.
Yes, sir.
Yes.
Sir, I
Where did you look
auscultation,
for
I just
bruit?
where all yes.
Where did you look? You mentioned no bruit felt. No bruit heard alvanama, felt antidiya.
Hurts.
Where did you look?
I looked on the cough region and the dorsum aspect of the foot, sir.
Yenakama calf regional, which vessel
Half
you get there?
Popliteal region, sir.
Popliteal, femoral, then you don't look for any abdominal aneurysm signs, huh?
Abdominal also, sir.
You should by heart Das. No other excuse. Yeah, all those points are given in Das.
Yes, sir.
Okay, Nikita, move on.
Sir, other systems.
So somebody please put
Sir,
Sir,
it up in the group where and all you should look for bruit. What bruit?
Yeah.
So
the
somebody
group,
put it up in the
write it
group
homework.
later. Where and all you have to look for bruit in
All
a
of them,
PVD feet.
let all of them put it up, sir.
Yes,
Write
sir.
and put it up individually. Yeah.
yes, sir. Other
Okay,
systems.
move on, Nikita.
Other systems, no significant findings noted.
No, you should look all the vessels in the body. Sir has told you, no? Upper limb, neck, all those vessels you should feel alone.
Yeah,
Peripheral.
that she has missed it. We have agreed that charting you have to mention.
Carotid, everything.
Musculoskeletal system and nervous system. What did you check for specifically, and how did you check?
Spine, sir, and
What in the spine?
movements of the spine, sir, and pain.
Movements of the spine. How will you check?
Peripheral vascular disease got the cane samandha.
Sir, musculoskeletal system for muscle point, power
Muscle.
grade we can check, sir.
Muscle wasting.
Muscle wasting, yes.
Where?
Limb girth.
Where do you look? He's asking.
Sir, we usually check the limb girth.
Limb girth. That is what I'm asking. Where?
Sir, lower limbs, the thigh will be measured from 9 centimeters from the above the patella, and 7 centimeters below the patella. We calf girth.
You measure and do what?
Comparison to the other side, sir.
Okay.
So
And what is its significance?
if it is lesser than the other side, there is muscle wasting on the.
Due to?
It's a neurogenic, sir.
Neurogenic what? Can
Neurogenic
neurogenic be
communication.
only unilateral?
Yeah.
Shravan, sir?
No, sir. This is muscle wasting due to arterial, no, sir. So basically,
That
patients
is what I'm
are.
asking.
When patient stops walking, disuse atrophy slowly. You can classically see in so many chronic patients.
No, but it will be most of the time bilateral, no? Or it can be unilateral
Sir,
also.
again, depends on the level, sir. Iliac, it will be bilateral.
Yeah.
If it is only femorotibial, it will be unilateral.
So it is important for them to mention, no, that
Yes, sir.
if there
Yes,
is
sir.
definitely gross muscle wasting.
Yes, sir. They should, sir. They should.
Yeah. Okay. And nervous system, what is expected nervous system?
Nervous system, nothing
Hyperesthesia
specific,
and
sir.
paresthesia ಅಷ್ಟೇ.
Yeah, just to rule out any spinal issues, sir.
Okay.
Sir, should we all
Okay,
check
Nikita.
for all the reflexes, and should I comment on them or no, sir?
If it is something abnormal, I think then you should comment. Otherwise, I don't think so.
No need.
Shravan,
No
sir?
need. No need, sir. No
Yeah,
need.
yeah. Okay, move on, Nikita.
Sir,
So diagnosis. Yeah. Summarize and diagnosis.
A 56-year-old diabetic and hypertensive male with previous left foreto amputation and Boyd's grade 3 intermittent claudication presented with ulcer over the right great toe and edema of right foot with decreased vascularity of bilateral lower limbs.
No, one more thing you have not mentioned, which is very important. Smoker. He's been a chronic smoker for 30 years, you have mentioned,
Yes,
no?
sir. Yes,
That is
sir.
also important, right?
Yes, sir.
Yeah.
Provisional diagnosis is peripheral artery disease with the diabetic foot with ulcer and cellulitis, sir.
Diabetic foot infection with chronic ulcer, no? That is probably due to
So
this one,
punched out
neuropathic ulcer.
ulcer on the great toe. What is the diagnosis?
Correct.
Chronic arterial ulcer, sir.
Hey,
It's not chronic arterial ulcer.
Neurogenic.
Punched out ulcer will be a trophic ulcer, no? What is the cause? It's a neuropathic ulcer.
trophic
Yes,
ulcer
yes,
with secondary infection.
Secondary infection, which is with underlying peripheral arterial disease. So, sir, should it be put like that or anything else?
One more thing. Now the accepted, as far as accepted classification in all exams is Rutherford. Unless the examiner asks about Boyd or Fontaine, it is advisable to mention the Rutherford classification only. Now, once the patient already has a wound, that means they already, for this patient, especially it's in the toe, they already go into Rutherford 5. So,
Yeah, correct.
it will,
Ulceration or gangrene. Yeah.
the patient used to be a claudicant. So, the examiner will ask, what is the patient having now? So, you should put the present status. You should not tell about the grade of claudication now. In history and all is okay. But now we should directly tell it's a Rutherford 5 stage only, sir. That's main.
No, how should they put the diagnosis, final diagnosis? Like chronic neuropathic ulcer with infection and abscess and
Both
PAD
should be
or
mentioned, sir.
straight
Both
away?
should be mentioned.
Both should be mentioned.
Both
With
should be
grade
mentioned, sir.
5 for the Rutherford this thing. Okay.
Yes, sir. Yes, sir. And side is very important, sir. Right side,
Yeah.
left side. She's not mentioned the side. So we have to mention the side.
Yes.
Some patients may have bilateral. If it's a young patient with verges, they may keep multiple toes gangrene in both limbs and all. So we have to mention the side.
Yes.
Why not Berger disease? This is
Age of the patient, usually Berger disease is below 40 years.
apart from age, anything else?
And that's
No, there is a classical trophic ulcer. No, burgers. I think it will not be there. It's just gangrene.
Just go through that list of criteria, and that list atherosclerotic risk factor should not be there. So in that terms, you are having diabetes, hypertension,
Diabetes
and all
and
that.
smoking.
Yeah.
Smoking should be there.
Smoking should be there.
Yes,
Should
sir.
be there.
No, sir. Smoking is there. Other than smoking, it should not be any atherosclerotic area, which is diabetes.
Yeah.
Yeah. Okay, Nikita. How do you manage this case?
Sir, and in burgers, it will be painful ulcers, right, sir? Because it is an only arterial thing.
Very painful it is. Patient will be sitting always hanging with the legs on his side.
Yes, sir.
Okay, Nikita. How do you manage this case?
Oh, this ulcer is due to peripheral vascular disease or diabetes?
Sir, ulcer is due to the peripheral vascular disease, sir, which is superimposed. The infection is
Peripheral.
due to
No, no.
the
Ulcer is due to neuropathic ulcer. Infection probably is due to what is it? Diabetes or underlying osteomyelitis. We don't know. And the third, it is worsened because gangrene is probably progressively worsening because of peripheral arterial disease. So, sir, can it be put like that or how is it?
Can't it be diabetes, or even diabetes will cause atherosclerosis and neurogenicity and
No,
go.
cause of the wound is diabetes because the patient already has a trophic ulcer,
Correct.
callus ulcer, and on the workup we have found a PVD. So the cause is
That is
diabetes
what. So
only.
diabetic neuropathic ulcer is the primary this thing, right?
Yes, sir. Yes, sir.
Yeah.
Okay, sir.
Yeah.
So further, for the patient management, we would like to conduct some investigations to confirm the diagnosis, sir. And
Okay. What investigations you will confirm the diagnosis?
sir, Doppler scanning to confirm the peripheral arterial disease, and to know the severity of the ulcer and cellulitis, an X-ray foot, sir.
First
No.
for culture sensitivity
No,
concern.
no. No. But sir, can she put it like that? Because the callosity with ulcer, you can talk about X-ray to rule out osteomyelitis. But that
Yes,
is
sir.
not to diagnose the ulcer. Diagnose the
Not to
cause.
diagnose, sir, just to see the severity,
Yeah. Okay.
to assess the severity of the condition, sir. The second one.
No, to assess how you have to manage this case.
There is no confirmatory diagnostic investigation. This is diabetic blood sugar. That's all. Nothing. What else?
For peripheral arterial
So
disease,
you
I
should
was
not
saying.
tell that you
To plan the
doing some
management, you have to do Doppler, angiogram, all
management.
those
Plan the management. You say you are doing investigations. One is routine investigation, and then there are some specific investigations.
things. To
Specific
plan the
investigations are HbA1c and your culture sensitivity and the Doppler.
Yes, sir.
Routine is other routine investigation, blood investigations. Shawan, sir?
Yes, sir. One line we can mention preoperative routine investigations, but directly most of them examiners will tell skip to what you want to see specifically. So that
Correct.
time we should mention first step should be X-ray foot and second should be arterial Doppler of the right lower limb.
And also the culture sensitivity.
Culture sensitivity, yes.
Yes.
Okay. Next.
One point
So,
I'd like to add, sir, in palpation,
yes.
actually the probe to bone test should be mentioned, sir.
Sir?
That has been missed. Probe to bone test. You should probe and see whether you're feeling a bone for any ulcer, not only this PAD case, for any ulcer. Probe to bone test should be done.
That is to signify whether there is features
The
of osteomyelitis or not.
Yes. Yes.
Yeah.
Carry on.
So X-ray, in this case, what was done?
Sir, first X-ray foot was done, sir, in AP and lateral view.
What did it show?
Sir, it showed some
There are some destruction this thing, no?
yes, sir.
Osteomyelitis changes are there.
osteomyelitic changes
Okay.
are there.
Yeah.
Yes, sir. Then
Okay.
Doppler was done, sir. It showed absent flow in the left saphenofemoral artery, and right side there were multiple atherosclerotic plaques and moderate luminal stenosis. So hence patient was
Okay.
planned for further imaging, sir.
What about the other vessels?
Sir, routine blood investigation, sir.
Allama, Doppler only. What
No,
about
no,
the
no.
other vessels?
Sir is asking about others, popliteal, tibial.
Sir, other vessels were there was no significant pathology, sir.
Where is the report?
How can it be? How can it be, Nikita? When you say absent flow in left SFA,
First, they should be affected.
Sir, they told there is decreased velocity, but the flow is normal, sir. Visualized flow is normal. Only
There are collateral, sir. Because of that, the
No,
flow was
see, sir's point is it cannot be normal. You cannot tell us normal. There may not be any
yeah,
stenosis or occlusion, but the flow will not be normal
There
naturally.
may not be critical narrowing.
The vessel, the
whether it is
velocity
monophasic or
will
what.
be velocity will be less, and the phasicity will be monophasic. That's what sir is asking.
Based on that only you plan bypass surgery, sir.
Sir, in the report, they had mentioned as normal, sir. Popliteal tibials, both the tibial arteries are normal.
So normal means triphasic flow.
It's supposed to be some, but they did not comment on the flow. But normal
No,
means
no, they have
yes,
to
sir.
comment. No, when you say normal, in the arterial Doppler if report, if you're seeing, they won't just write it as normal. They will just mention the flow. Shawan sir, am I right or?
Yes, sir. Ideally, they're supposed to mention the velocities and the phasicity, but our Dopplers, they don't mention the PSV only, sir.
Oh, okay. Fine. So there is this finding. Based on this, what will you do next?
Sir, further imaging, sir, MR angiography.
Is it indicated in this case?
Yes, sir, because
Why?
there is as per the Doppler, there is absent flow in the saphenofemoral artery, and also
But you said the distal flow is normal, no?
So where is
And
the
that too, that is on
no,
the left side. This is on the right side.
lesion is on the right side.
right side also shows moderate luminal stenosis, sir.
Moderate luminal stenosis.
But you said distal flow is normal.
Yes, sir. But pulse clinically it was feeble, no, sir. So
No, no. So you have to justify how you answer. What sir is asking is whether MR angio is immediately necessary or you have to go ahead and take out the source of sepsis and then you have to evaluate further, or you have to evaluate first and then you have to go.
Angiography is required when there is any need for any surgical intervention. You said posterior tibial and anterior tibial flow is normal.
yes, sir. As per
That
the
means that means the patient does not require any vascular interventions.
Shravan sir?
Sir, there was occlusion in the SFA with all monophasic flow below. So because the patient clearly
Okay.
required an intervention, that's why MRI angio was done. That's why you have to tell Mark.
Okay. Correct. So if you answer that it is normal, then these questions will come. Suppose there was no gross problem in the flow, so except this moderate like monophasic or biphasic flow, then also MR angio is mandatory, or you have to go ahead and take out the osteomyelitic segment to see how the wound is healing and then evaluate, or you have to evaluate in all cases. That is what the question was, sir.
Can be done depending upon the response of the treatment, I think.
Sir, anyway, they'll keep a classical case only in the exam also. So it will definitely show some changes. So I think there they won't have any issues. Sir.
Okay. So the answer should be if there is some disturbance in the flow on arterial Doppler and the pulsations are not felt, do an MR angio first
yes,
and then go ahead with the procedure.
Please go through the indications for angiography and put it in the WhatsApp group.
yes, sir.
Okay, what was done?
So MR
Or what will
angiography
you
was
do?
done, sir.
Hmm.
So it showed actually
Doctor,
consist.
before that, you want to mention something, Doctor? You took him to the OT also, no?
Sir?
You took him to the OT also, right?
Yes, sir.
So because he had an infected wound, just to drain out the collection there,
Debridement.
debridement was done, necrotic tendon excised, and the purulent collection was drained. Then to revascularize, because there is a plan to revascularize, MR angiography was done.
So first
Okay.
surgery was done and then MR angio.
Good, Doctor.
Sir, here first MR angio was done, then the plan for.
I'm telling for exam.
Oh, okay, sir. Okay, sir. Okay.
See, that is what my question was earlier. When there is a active infection, you drain out the infection first, and then probably go for the MRNGO and then revascularize.
Yes, sir.
Yeah. Okay. Okay.
What will
What
happen
was
in
done?
exam scenario? The patient will be having the MRI, the examiner will be having the MRI films with him. Okay. Then once you see the wound and all that, we will tell sir the wound is infected, pus is coming out. I would like to take him to the OT and drain out the pus. Next, I would like to find out where the lesion is by doing an MR angiography, so that because I can plan an intervention. Then they will put up the MR films. Then they will tell we explain the MR films. Understood?
Yes,
That sequence should maintain.
sir.
Same
Okay,
patient.
sir.
Let's say the patient had a dry gangrene. Then that issue doesn't come at all. Directly, you can tell, sir, patient has dry gangrene, requires some form of revascularization. So, to know more information about where the lesion could be, I want MR angiography. Directly there you can go.
So you
So,
understood, no, the difference.
Yes, sir.
So
Yes.
if it is wet gangrene infective setting, you have to talk about intervention and taking out the source immediately, and then later go for evaluation and intervention. If it is dry gangrene, no, you should mention about identification, correction of the this thing blood supply, and then going for intervention. Because what happens in that case is there will be progressive dry gangrene if you don't intervene there. If you just take out the toe, it will again next to 1 or 2 days, it will keep progressing.
Yes, sir.
Okay. Yeah. Move on. So what was done here?
Sir, debridement of the wound was done, sir.
Okay.
There was minor abscess beneath the wound, so it was
There is nothing like
right.
minor or major abscess. There was abscess,
There
which
was
was taken care. Correct.
Yes,
Yeah.
sir. Yes, sir.
I think you people should avoid this mild, moderate, minor, all those things.
So don't talk about minor abscess, minor debridement. Just tell that there was abscess and there was necrotic tissue which was taken care of. Debridement was done. Drainage of abscess was done. Okay.
Yes,
Toe
sir.
was disarticulated or
No, sir.
reamputation was
No,
done. What
sir.
was done?
No, sir. Only the drainage of abscess was done and wound
Why?
debridement was
Because
done.
there is osteomyelitis.
Nowadays, some surgeons try conservative for, I think, osteomyelitis also.
Trial of
Sir, is it accepted when there is osteomyelitis to go for only debridement?
Vivekananda, I have seen doing this.
No, that's what I'm asking, Shawan
Hmm.
sir.
But when there is
Shawan sir is there?
hello, I'm audible now, sir.
Yes, sir.
Yes, sir.
Yeah.
Only for frankly infected, completely joint is destroyed, bone pieces we can feel through the wound like that. We directly go and remove the osteomyelitic segment and all that stuff. Otherwise, we can
Okay.
try prolonged antibiotics and try to avoid amputation.
Okay. But in this, it looked like that entire toe had abscess and all that,
No, sir. Clinically, it was not so much.
and the plantar aspect.
Yes, sir.
Okay.
Clinically, it was not so much. Only the uh, tendon was necrotic and there was an abscess there, which our students painted out.
Okay.
Yeah.
And then, Nikita, what was done?
and then patient was planned for angioplasty, sir. So
Okay.
right-sided
What was the
saphenofemoral
MR angio report? You didn't tell.
artery. Sir, it was same
Huh?
as it was same as the Doppler, sir. They commented on the occlusion of the right femoral artery. It's, but the lower arteries were normal, sir, even in MR angio.
Okay. So what was the indication for intervention here?
Occlusion of the right femoral.
No, but distal supply, blood flow, everything is right, no? And you have ulcer on the distal part.
Yes, sir.
So what is the answer for that? Vinod?
Hello.
Yeah.
Sir, one is monophasic wave, sir, in Doppler, which is showing, and there is an
No,
ulcer.
forget Doppler, man. Doppler has already been done, and after that, MR angio is done.
Yes, sir.
So you can't explain based on the Doppler report.
Yes, sir. Sir, there is a non-healing ulcer, which is so that itself will indicate for
No, non-healing ulcer, how did you say? You have just done the debridement.
sir, it's a
The
chronic ulcer.
debridement, the recovery was not so satisfactory, sir.
No, see, it's very clear.
How?
What Rutherford stage is the patient?
5.
Grade 5.
So Rutherford 5 is chronic ischemia or critical ischemia?
Critical ischemia.
Correct. Critical ischemia requires the blood flow to be corrected, yes or no?
Corrected, sir. To be
Very
corrected.
simple. Very simple.
Yes, sir.
Okay. When
Yes,
you
sir.
have a documented occlusion with a poor, with a Doppler collaborating with a low arterial flow.
Yes, sir.
Yesterday, Dr. Nitya was also telling about Wi-Fi and all that. No,
Yes, sir. Yes, sir.
the patient would directly come under Wi-Fi stage 2.
Yes, sir.
Okay. So, Rutherford grade 5, Wi-Fi stage 2 with an abscess of the toe and documented occlusion with poor velocity monophasic waveforms in the tibial. Very
Yes,
clear
sir.
indication to go and correct the occlusion.
Yes, sir.
Okay.
Yeah.
So,
So you should
with
know how to justify that. When you say
Yes, sir.
that, you can the what sir has answered that all those things should be told in the exam. Why you want
Yes,
to
sir.
correct the flow?
Yes, sir.
Yes, sir.
sir is asking this because naturally the examiner will tell why we can wait and see, what is the harm in doing it like that. Okay.
Correct,
So
Yes, sir.
correct. So
you should
collaterals
tell
are
like
there.
this.
Distal flow is normal. So that they will try to argue like that. So you should have a justification.
Yes, sir.
Okay. So what happened now after that? What was done? What was done? What intervention was done?
Sir, angioplasty was done, sir, right-sided.
How? From where?
Endovascular,
Or
Only angioplasty
Hmm?
or anything else was done.
stenting was done, sir.
Yeah, you mentioned that. Not all angioplasty
That is what
operations. You should mention, right? Superficial
stenting
femoral artery,
where. All
angioplasty
those things
and
you should
stenting.
tell.
Hmm.
Yeah, go on, Nikita. What was done? After that, what
Angioplasty.
happened?
Which vessel angioplasty was done?
Right superficial femoral artery, sir.
Okay.
Uh, uh, Post that, wound was relatively healing well, sir.
Hmm.
My doubt is the only superficial artery angioplasty will it improve the flow up to the toes?
Sir?
Only superficial femoral artery angioplasty will improve the flow up to the toes?
Yes, sir. The flow was
That was
good,
the
sir. On
occlusion
table
time.
angiogram we did. In that the flow was good, so only the SFA was corrected, sir.
No. That's what in general, only if you do that angioplasty will it improve the flow throughout the leg.
If there's contaminant tibial disease, we can do a tibial angioplasty also
That's what I'm asking
together.
whether
For this patient, there was no need, sir. The anterior tibial artery was very good, going down all the way. Peroneal and posterior tibial mild disease was there, so we didn't touch that. And we generally look for at least one target vessel to go down all the way, sir. And for him, because the anterior tibial was very good, and on table after stenting, we got a palpable DPA, so we didn't proceed any further, sir.
Sir, my question will be here. Will the claudication pain completely go away after this angioplasty?
Yes, sir. We will not have any claudication pain now. Our target now is wound healing, sir. So
Okay.
claudication pain is only a
if there is
additional
wound healing,
byproduct.
complication pain will definitely go.
No, but wound healing and wound being there is nothing related to claudication pain. That's what my doubt was.
Yes, sir. So his claudication will definitely improve because we opened up
Okay.
the flow to the car. But that is just a additional bonus which we get in this, sir, because our target here is
Yeah,
wound healing.
correct.
So as a
Okay.
byproduct of the treatment, his claudication also goes away. So that's acceptable, sir.
Oh, okay. So my question was, is it like always will it completely go away, or there will be some residual this thing which will might remain even after stenting?
So for this patient, it will go away, sir, definitely, sir.
It will go away. Okay.
It will
Okay.
go away, yeah.
Okay. Nikita, what happened later?
Yes, sir.
Name the vessels on the MRI. Can you show which are the name the vessels? Which is the popliteal, which is the anterior tibial, which is the peroneal?
Sir, medial is the
Start from the
anterior.
top. Start from the top always.
Top.
And tell.
When
Aorto,
the film
iliac,
is given to
aorto,
you,
iliac.
you should always start from the top. You should tell first of all whether it is a CT or MR, and then start from the top and go down.
Yes, sir. MR angiogram, abdominal aorta with renal arteries, then the common iliac arteries bifurcation. Internal iliac and external iliacs. In the external iliac, superficial femoral and this is profundus artery. This is the popliteal artery, sir.
You forgot the main target vessel only. Superficial femoral full length.
This is the superficial femoral.
Yeah.
Yes, sir. Then the popliteal artery. Medial is the anterior tibial artery.
Medial is the
Anterior tibial, sir.
Medial you
Yes.
palpate what?
Sir?
Medially you palpate what?
Hmm?
Laterally,
Yeah, one answer, one of you answer. Both are answering. We are not able to hear.
Medially posterior
Quick
tibial.
answer.
Yeah, medially between the malleolus and the heel, what will you palpate?
posterior tibial arteries.
Ah.
Laterally is the anterior tibial artery.
Anterior
Yeah.
tibial artery.
That one. Yeah.
Which is the peroneal?
The posterior, sir. In between them is the
what is that short vessel?
Where?
Proximal to the
this one.
proximal to the peroneal. You trace the popliteal down.
Yes.
It's dividing into 2 or 3.
3 it is dividing into, sir.
No.
It's dividing into two, and the other one is dividing into two.
Yes. So what is the popliteal dividing into?
Tibial and peroneal, sir.
Popliteal dividing into
Anterior and
anterior tibial and tibioperoneal trunk. Tibioperoneal trunk divides into posterior tibial and peroneal.
So peroneal, yeah.
So that short thing which you're seeing is the tibioperoneal trunk.
This okay, sir.
Okay.
Yeah.
Yes.
Okay. So what happened eventually after this?
Sir, wound was healing well, sir. So patient was discharged with oral anticoagulants.
Clinically, what happened?
Distal pulses were
Which pulse?
dorsalis.
Tell all that.
Okay.
Yes, sir.
Okay. Then how long will you give anticoagulation, and what anticoagulation or antiplatelet? You give anticoagulation or antiplatelet?
Antiplatelet, sir.
So there is a difference, no?
Yes, sir.
Yeah. What
We'll give,
antiplatelet and how long?
so we'll give for at least of 6 months, sir. 3 to 6
No,
months.
it is lifelong.
Lifelong. Sir, in this patient, sir has
Yeah.
given anticoagulant, sir, for 2 weeks. Sir.
Yeah, you forget
Then
this
sir told
patient.
he'll
What
continue
you
with the
should take
antiplatelet.
first. Forget this
What is the
patient.
exam answer? What you
Yeah,
should tell?
exam answer you tell.
Yes, sir, antiplatelets.
What antiplatelets?
Uh, Ecosprin with clopidogrel. Sir.
Never tell Ecosprin.
Aspirin.
Aspirin.
Aspirin. Yes.
Aspirin. Is it both or is it only single is enough or
Both, sir, both.
any
Evidence,
other? Hmm?
Both, sir.
both
Both, sir, for
both
lifelong.
is superior.
Both for how long? Both for how long?
Lifelong.
Is it lifelong
Lifelong.
or initially both and later single?
Both, sir, for lifelong.
Sean sir, is it both
No, sir.
or
Both
initially?
for 6 months and then single.
Yeah, correct.
Only
Correct.
aspirin lifelong.
With statin. Never forget the statin.
Statins.
Statins, yeah. So all these things are important. Why in this case anticoagulant?
Sir told in this case because severe calcifications were there, which is so the stenosis is there. There is high chance of formation
Thrombus.
of yes, sir.
It is a
Okay.
long, highly calcified lesion with significant recoil after stenting also. So we put
Yes,
on
sir.
anticoagulation.
Yes.
That is short term only, I think.
Short term, 3
Yes,
months.
sir.
That's all. 3 months and then we'll change of
Yeah.
antiplatelet.
And it is Novak,
I put on
novel
rivaroxaban, sir.
anticoagulant.
Yes, sir. But in
Rivaroxaban,
exam we should tell acinocumarol only, sir.
Acetrom. Okay.
Yes, sir. We should not tell about Novax.
Acetrom is it helpful in arterial disease?
Sir, acetrom when
No,
there is
not in.
not for exam, sir. Not for exam. But if at all, some patients will have some acute component with chronic component mixed. For those patients, we can put on acetrom.
Thrombus formation to prevent thrombus formation.
Yes, sir. Yes, sir.
Yeah.
And sometimes the patients who don't have clear flow going down to the feet, for them also we put on anticoagulation. Only from midfoot till midfoot we would have been able to improve, and then only collaterals are there. So those kind of patients we put on an additional anticoagulation.
After this procedure, if the claudication persists or if the wound doesn't heal satisfactorily, what will you do?
Nitya,
Amputation.
Nikitha.
Nikitha, sorry.
Answer.
So we'll plan for the amputation, sir.
No,
Where
first you have to
amputation?
find out the cause, sir. That is why sir is asking.
You
You
have
have to
said
find
DPA is
the
well
cause.
palpable. DPA is well felt. No.
Yes, sir.
So you'll if it wound is not healing, you'll straight away go and amputate. Where? Amputate where? You mean below knee amputation?
Sir, we'll find for the
Answer.
second blockage again, like from where the occlusion is, or
Dorsalis
No.
pedis is palpable.
But dorsalis pedis is palpable. When dorsalis pedis is palpable, how can it be anything distal there?
Osteomyelitis may be the cause for
Then
that.
it has to be a
Yes,
local cause.
correct.
Yeah,
Correct.
local infection there. So that is what you have to do. So you have to take out the source of the osteomyelitis by doing a reamputation.
Yes.
And if it is progressing beyond the foot, then only there is role for other amputations. If the sepsis prolonged, like increases, because you have taken care of the vascular component by doing a angioplasty and stenting, where the flow is shown to have improved. So if that is disease is progressive, then it has to be infection.
Shravan,
Huh?
instead of angioplasty, can you go for this bypass here, femoropopliteal?
Because it was only a short segment, we went for angioplasty, sir. It
No,
was only the distal
which one gives
SFA.
better results?
Sir, for short angioplasty is good, sir. For long, definitely bypass, sir.
Okay.
If the same patient had a long, complete length of SFA occlusion,
Segment, yeah.
100% bypass, sir.
Okay. Anything else here? So patient is eventually doing well.
Yes, sir.
No, you're not taken out the toe or anything. If the wound is
No, sir.
healing.
No, sir. Wound is healing relatively
Okay.
better.
Why should you do
So what do you
reamputation? Why
mean by
not only
relatively?
disarticulation?
Sir, not completely satisfactory yet, sir, but in comparison to the before angioplasty, it's good, sir. Maybe it will take a week or more to come in completely.
No, sir asked you some question.
Sir,
If you have to take out, why reamputation? Why not disarticulation?
because the joint space is also involved here, sir.
No. That is not the answer. No. Why you do reamputation? Why you won't do just disarticulation and leave it?
For the
Okay, for this patient, do you want to do a complete toe amputation?
yes, sir, reamputation. If
No, why not
Complete.
disarticulation of the distal joint?
Yeah, exactly.
That
Partial
is
toe
what sir is
amputation is more
asking.
than enough. That is why sir was asking that question again and again. Partial toe amputation at the IC joint is enough
See
for this
here, the
patient.
osteomyelitis is only in the distal part. The proximal part is preserved. So you can get away with only doing a disarticulating only that proximal the distal one. So you can preserve the proximal interphalangeal joint there, and then you can just leave it there.
sir,
If it is involving if it is involving the entire toe, then why? Then the other question comes: why reamputation? Why not only just disarticulation? For that, the answer is the head of metatarsal acts as a pressure point. Here, if you see proximal and distal interphalangeal joint, only the distal thing has osteomyelitis there. Proximal
yes,
this thing is normal. There, next to that, right side, that, and there is a cavity kind of a thing. No,
yes, sir,
no,
yes, sir.
there, above that. There, no, the edge. There, below that full entire thing. See that part is eaten
Still
away.
lucency.
So the rest of the joint, everything is normal.
Joint also appears a little. So okay, sir.
Okay, that's what it depends on what. Eventually, if that is preserved, if you can also see intraoperatively if there are any crepitus and all that in the bone there, you can take away that also. But here, if it is only there, you can try to preserve the this one, rest of the joint there, that toe.
If patient
Yes, sir.
patient says I don't want partial toe amputation, what is the next option? I don't want total amputation. I don't want partial amputation also. So what is the next option?
What do you do then?
Uh, can we just remove the infected bone portion, sir? Like,
Yes, you can just nibble
Yeah.
out the infected bone portion. See for the stability of the joint and stability of the toe. If the toe is stable, most likely for him, if the toe will be stable even after removing the infected bone, then nothing else more additional. If the joint feels little unstable, then you can always put a K wire and stabilize the toe.
okay, sir.
So what are the results there, sir? In an infective setting, in putting in a K wire.
Sir, this will be like arthrodesis they will do it, no, sir, in ortho. They would remove all the
Okay.
infected bone and
Okay.
they'll try to put some calcium beads along with the K wire.
Okay.
So good results we've seen with that.
Will it work with good results?
Yes,
Are
sir.
good.
Yes, sir. Yes, sir. We've seen good
Okay.
results, sir. Affordability is the only
Okay.
issue, but otherwise we've seen good results, sir.
Okay. So if there are no more questions, anything else from anyone else? Any questions or clarifications you want?
Sir.
So final comments. Nitya.
It was a little bit half this thing presentation, sir. I think she could have improved on her history and examination. I think since it's the first clinical presentation, I think she would do better in the next coming
No,
presentation.
it's not her first. It is definitely not her first.
I think for the
Nikita,
PGs, your comment should be harsh.
The first peripheral vascular disease presentation.
first peripheral vascular disease, but it is definitely not your first presentation.
Exam in the exam
Sanya?
you can be in the exams you should be soft, not in the clinicals.
So same
My
thing I felt, sir. Little more bit preparation was required.
Yeah. Shrikant sir?
Not up to the mark. You should by heart that Das thoroughly.
Yes, sir.
Sean sir?
I stand with Shrikant sir, sir. Same thing. Basics has to be even more stronger. And I would suggest
Yeah, because
students
No
can
one
present to
will
each
fail
other,
you
sir.
for angioplasty, MR angiography, all those things.
Yes, sir.
Sean sir was
I,
telling something. Yeah.
students can present to each other and see, sir. One person should act like a examiner, and they should try to find fault with what is wrong in the presentation. So
Always
when
find fault.
Correct.
yes, sir. So
Because
that
this
is
is
one
where
way
you, if you
to.
find fault, you will get better in the
Yes, sir.
exam.
That's what we used to do, sir. We used to present to each other, find out what we were missing, and correct on that.
Sir, this
See, the
claudication pain.
thing.
Hello, sir. This
Ask.
claudication pain, where to update, sir? Because patient right now complaint is in the foot area. So should we explain it in the history of present illness or in the something like a past history?
They both should
No,
come
in
in
the
the present
present illness
history.
only. You have to talk about rest pain, you have to talk about claudication pain, you have to talk about the other pain, that wound pain or leg pain or whatever, continuous pain when
Okay.
there is
Okay.
infection. So
Okay.
all three you should mention here.
No, sir. Like
Okay, sir.
in chronological order, should we comment it the first or in the like
Chronological
negative
order,
history we can?
what was there first?
The claudication
Patient
pain.
had an ulcer. Ideally, in this case, it will be probably a chronic ulcer. Ideally, it looks like it's a chronic ulcer, along with probably claudication pain, short history of infection, where the patient has started to have wound pain due
Breast
to
pain
infection.
and claudication pain should be in the present one complaint, history of present illness.
Okay, sir.
Yeah.
Very simple.
So, Nikita, your presentation needs lot of improvement, and in especially in these cases, they will straight away fail. There is no other. They won't even go into anywhere in diagnosis and management and all that. If you do even a slightest mistake in your presentation in a case of ulcer, see ulcer, breast, and hernia, there is no question of even doing a single mistake in your presentation. So there is no like forgiveness or whatever. I think Sanya and Nitya can comment. So they will they because they have finished the exams very recently. So they will straight away fail you. They won't even go into discussion and all angioplasty and all. They won't go. So basics have to be at the best in all these three cases of breast, ulcer, and also hernia and thyroid. All these four cases, all your basics and all your presentation should be up to the mark. Not even a single mistake there. So if you do that, then only you will pass.
So apart from that, any other for the case
Norman Bros.
presentation, anything else
I think Norman
students have
Bros.
to
The DAS
sir?
and then
Das is the
Hamilton
basic.
Bailey.
Hamilton Bailey and Norman Bros is there.
Yeah.
No, for case presentation format, sir. Are our students using anything else?
Usually they follow Das only, sir.
Yes,
I
sir.
think
So
now there are options.
yes, sir. My suggestion, sir. There's a book called
Yeah.
Rajamahendran. There's a
Okay.
separate Rajamahendran for long cases, and there's a separate larger Rajamahendran for short cases. Both are fantastic.
Okay.
It gives a nice,
Okay.
clean outline of what and all to miss, what to ask and all. From history to examination and discussion also is fairly covered. So if they're interested, they
Okay.
can try
So
that.
please make note, everyone.
Yes, sir.
Is it available everywhere?
Available everywhere, sir. Available everywhere.
Okay. Yeah.
Rajamahendran long cases and Rajamahendran short cases.
Okay, good night.
Okay, I think if there are no more this thing, we will end it, sir. Thank you. It was a good
Thanks.
discussion.
Yes.
Thank you,
Thank
sir.
you. Thank you, sir.
Good night. Good night.